Screen. Good morning. So, okay, perfect. So when we're, working in the emergency department, you may come up with a clinical question and you may say, "Oh, I've heard about the bougie and I'd like to use it, but is it better than using a normal stylet when I'm intubating patients?" And so I asked Dai if you have, I know you have bougie available in Chorai. How about some of the rest of you? Are you guys using a boot? First of all, do you know what I'm saying when I'm saying bougie? And second of all, are you using them regularly when you intubate patients? Kit, what do you think?
Uh, in in my department, we usually use stylet.
Okay.
Uh, at the first time, uh, we just use bougie when it's hot to intubate. Mhm.
Yeah. And that's actually common. That is generally the way a lot of departments are doing that in the US as well. Tu, how about you? Are you using stylet or bougie or both?
The same not a gig. Start
Okay.
at first and then
Okay. Juliet, how about it, Davis? What are you guys using kind of stylet as your generally as your first setup?
Yeah, the residents here use the stylet first. A lot of them will just carry the bougie in their pocket, but I
Mhm.
haven't seen anyone use bougie for their first pass.
Okay. Interesting. So yeah, we can ask the question, should we be reserving bougie as kind of a rescue technique, or maybe it's making us better at our first pass, in which case we might not need it as a rescue. We could just use it as a first pass. So we might be asking ourselves the clinical question, does bougie increase first pass success? When I asked our residents at Fresno this question, um, and we put them in a poll, um, this was kind of their answers. And so most of them believed that bougie increases the first pass success, and yet most of them are still using stylet as their initial airway management tool. And so this will give us a chance to kind of talk about evidence-based medicine and not just in the theoretical, sit down at a desk and read a paper, but how can we apply this to our practice? Some of you might appreciate the slide that the resident used. This was the resident's title slide. The journal hour is bougie, but that might lose some in the translation. So I changed it up a little bit. So evidence-based medicine is not only the relevant scientific evidence, which is what we see in red, but also we're incorporating our clinical judgment, which can incorporate our interpretation of that, and also taking into account what the patient's values and preferences are. And so learning the scientific evidence, reading the literature is just simply one part of evidence-based medicine. And I like this quote from Belomo, but in as us as emergency medicine physicians, it's all of our responsibility how to ask the right questions, how to find the answers by looking through the literature, and then how to critically appraise the literature, how to look at it and say, does this answer the question that I'm asking, and how do I apply that to my practice? So just as important as you knowing the details of how to treat acute coronary syndrome or how to treat a multi-system trauma, in my mind, just as important is knowing how to analyze the literature. And so, as a basic outline for this, we'll use the PICO technique. There are other ways to do this, but this is just kind of a simple approach to taking a look at a piece of literature and looking at the methodology of it. And so, the PICO approach is looking at the patients, looking at what intervention that we're measuring, looking at the comparison for the paper? What are we comparing that intervention to? And then looking at what is the outcome that we're actually measuring. And we'll see how this is important when we are analyzing these certain papers that I sent you. So the paper that I sent you is called the Bougie trial and is from 2021, so a couple years old, but they basically did a randomized control trial comparing Bougie with stylet for first pass success when they intubated. The author is a doctor named Driver, who is based out of Hennepin in Minnesota. And so the first thing, which I think is always fun to do whenever they have an acronym for a trial, is look at see how well they did. And this is also probably a little bit beyond the scope of this talk, but they really kind of stretched to make this spell bougie. They kind of cheated a little bit. They skipped a bunch of words, but overall, it's maybe a C plus as far as title goes, calling it the Bougie trial. The methods of this trial, so it's a randomized controlled trial, so they're comparing two different interventions, and it's multi-center. This is important. They looked at 15 different sites. Some of them were emergency departments, and some of them were ICUs. It's unblinded because it's obvious when you're intubating whether you're using a stylet or a bougie. And then this is a pragmatic trial. And I think that's important to note. When they say pragmatic, what they're saying is we're looking at this in real life conditions, not just ideal conditions or laboratory conditions, but we're looking at it in the way that it's actually used in practice. And so, for example, when they are saying, this is pragmatic, the doctors, they say you either are randomized to using a bougie or a stylet, but everything else is up to you. Do everything else the way you would normally do it. We're just comparing this intervention. And so the doctors could really use the strategy that they felt most comfortable with. And that's what they mean by pragmatic. This is like the way it's done in real life. And I think that's great because that gives us a sense in real life what the outcomes might be. So for this trial, if we had a chance to look through the methodology, the patients for this trial, there's 1,100 patients, and the inclusion criteria, these are adult patients undergoing intubation with sedation, and then they're using a standard geometry blade. I want to point that out. It's different than the hyperangulated blade. Anybody who's tried to intubate with a hyperangulated blade with a bougie has probably realized that that's actually quite tough. You need that hyperangulated stylet in order for that blade to work. But with a standard geometry blade, usually meaning a Macintosh blade, which I'm guessing that's what I've seen used at Chorai, and I'm not 100% sure about the other sites. And like any trial, there's a certain exclusion criteria. We typically exclude pregnant people, prisoners. And in this trial, they did not include, and we're going to revisit this, patients who needed immediate intubation. They didn't have time to randomize them. So that probably includes people who required like CPR or who are acutely ill. So keep that in mind because we're going to revisit that later. The intervention that we're measuring is using bougie for your first pass. And then this is like the description of what they said. And then we're comparing using bougie to using an endotracheal tube with a stylet. I think that is very straightforward and easy to understand. They recommended how to shape the stylet, but again, this is a pragmatic trial, so people can use the stylet in however manner that they want, just with this recommendation. And then the outcome that we're measuring is first pass success, and that's defined as looking in with the blade and single pass of the tube. So it's a pretty strict definition of first pass success. But then they also measured, the slide fell out and I apologize. They also measured secondary outcomes of time that it takes to intubate, and also episodes of hypoxia. So those are secondary outcomes that they measured. So I don't think we need to go into the pros and cons of the study design, but overall, this is a pretty straightforward and well-designed study. And so what are the results that they found in this RCT from 2021 that's multi-center. First pass success rates were 80% with the bougie and 83% with the stylet. So this did not reach statistical significance, so relatively equal. They were about the same for first pass success. For the secondary outcomes, the bougie and stylet were fairly similar with relatively low episodes of hypoxia. The time, and they're measuring this time from the onset of sedation. That's why the time looks so long. 124 seconds is 2 minutes. Like that sounds like a long time to intubate, but they're measuring from when they first pushed the sedative before the paralytic and before the attempts at intubation. Those were relatively similar with maybe a little bit favorable of the stylet. They also measured mortality. Mortality was higher in the stylet group. I only mention this is because this is an outcome that I think you would be hard pressed to actually tie in, and this is probably statistical noise. It's hard to draw a link between using a bougie or a stylet to ultimate mortality unless you found that one of those was like failing drastically and you had profound hypoxia or you weren't able to get the first tube in. So sometimes some of these results, even though these numbers are different, may not be as relevant. You know, mortality is such a downstream result here. So when we look at this study, the strengths of the study is multi-center. We're looking at it in different places. They had good randomization. The way they did this was they had research assistants gather data immediately. And then like we talked about, the pragmatic represents the real life interventions and what it might happen the way you do it in real life. But there's also a lot of limitations to this study. They were measuring both the ED and the ICU. So maybe there's differences in the patient population up in the ICU compared to what we want to know is in the emergency department, is the bougie helping us? It's unblinded, so maybe there's some bias there. And they also had a wide range of levels of training. So they were using residents and fellows and attendings, and perhaps the different groups have different rates of success depending on their skill level. But one of the main limitations when I look through this is this inclusion criteria or the exclusion criteria for people that needed immediate intubation. Like we already know that many of us use the bougie when we are looking at a more difficult airway. And so, for example, someone who might be very, very sick or getting CPR, for example, those are some of the patients that I think bougie actually does make a big difference. And we excluded them from this trial. So we may be missing out on the benefit of bougie giving us a benefit in patients getting compressions, for example, because we don't know those patients weren't in this trial. So looking at the methodology and who's the inclusion and exclusion criteria actually really helps us say, is this conclusion relative to or relevant for my practice? Another exclusion criteria is if the operator felt that one modality was required as opposed to the other. And so there also may be cases when they're like, oh, these are clearly, obese COPD patients that I think bougie is really going to help. We excluded them, so we may lose some of the benefit from those patients. So it's a good trial and the findings are interesting, but we may be losing some of the benefit. And what's interesting is we can now, a good way to analyze the methodology is comparing this to a previous study by the same author, Driver. And I mentioned that he trains at Hennepin in Minnesota. In Hennepin, the residents generally are trained to use bougie as their initial airway modality. And so the initial trial that they did in 2018 was also an RCT, and they were comparing the same thing, bougie to endotracheal tube stylet. So it sounds very similar. And they actually did a better job of coming up with a acronym for their trial, because this at least is all like initial letters, BEAM, Bougie and Emergency Airway Management. So they get kind of that's like an A minus for acronym for their trial. But this trial was designed similarly. It was a pragmatic trial. And they also compared Bougie to Stylet and had similar outcomes that they were measuring. And sorry. Boop, 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 boop. These got copied into the wrong place. Let me skip. Oh, I know what's happening. I am pressing the button in the wrong direction. I'm like, what on earth is going on here? Let me skip forward here. Let's go forward instead of backward. So the results for this trial, the BEAM trial, give us very different results, right? The Bougie first gave us 96% success rate, and the Stylet was giving us 82% success rate. This also reminds me that from the Bougie trial, those initial first pass success rates were quite low, right? I think most of us think of ourselves as better than 80% when we're intubating somebody. Part of that is the strict definition, just a single look and a single pass, but still, that may represent that they're either very difficult patients or the operators were less skilled. Because here we see Bougie up in the 96%, which is very, very high compared to Stylet. So that shows an obvious advantage to Bougie. So when this trial came out in 2018, it maybe started convincing people that they should use Bougie. When they then compared that to the 2021 trial, it was like, oh, maybe there isn't a difference. And so what explains this difference? And so it's also an RCT, but this was at a single center. This was just at Hennepin. This was their initial trial. The remainder was similar, unblinded, pragmatic. They had a 760 patients, so decent size. Inclusion and exclusion were similar, although for this, they included patients that have difficult airway characteristics. So they were already selecting for patients where they might see a difference, because they were like, you know what, both Bougie and Stylet are probably pretty good for your average patient, but let's see if it makes a difference in the patients with a difficult airway. And this is how they define difficult airway. So obesity, a short neck, facial trauma, people that were in a C collar, right? And so those might be people that we expect to see Bougie showing us a bigger difference, as it did. And then similar exclusion criteria. And the intervention was the same using a Bougie. The comparison was the same using a Stylet. And the outcomes were also similar, the first pass success. And so we saw 96% compared to 82%. And for secondary outcomes, hypoxia was also similar, and time was also relatively similar. They measured time more like we're used to seeing, I think, once the operator started the intubation rather than from the onset of pushing medicines. And so again, this is a good trial and it's RCT. They had a high adherence to their protocols, real-time data collection. It's pragmatic, so those are all similar. Its strength is that they selected for difficult airways. But what are some of the limitations? Again, unblinded. Maybe the Hawthorne effect, maybe people are performing better when they're being watched. And that applies to probably all of these since it's unblinded. But the biggest limitation is that this is at a single center. And at this single center, the residents are being trained as Bougie first. A rough tie, we could call them Bougie files. They love the Bougie. And so these are people that are already practicing and favor the Bougie. And so it's no surprise that they're much better with a Bougie than they are with a Stylet. So the limitation that, since this is a single center, might simply be this reflects practice patterns at this site. And so that might explain some of the differences. And this is why exploring the methodology, because if you just read the title of these papers and you just read the conclusions, they come to vastly different results, even though they're both randomized controlled trials. And so this shows us in a very kind of straightforward way how important it is to just look through that methodology, use that PICO criteria, and identify, hey, what might be biasing or what might be confounding the results from this study. And this shows you, though, that a lot of these studies for airway interventions, for the utility of ultrasound, for the speed of vascular access. Almost all of those things are at some point going to, or even, radiology read something. It's going to depend on a human being and their skill set to do that intervention, whatever it is. So if you're looking at, the accuracy of a CT, or you're looking at the utility of an ultrasound, you can imagine if you're comparing someone who's brand new at ultrasound and you're comparing them to Tu, who helped us with the Rush study many, many years ago and presented at VSEM about it. She has a lot of skills in ultrasound. And so if I'm trying to compare ultrasound, it really depends on who I'm asking to do that procedure. Just like it is here, it really may depend on who is performing the intubation. And so the study does show that with, deliberate practice and with regular use of the bougie, you can end up with a very high first pass success rate using the bougie. But that result may be lost when you're comparing that to people in other institutions where they're not preferentially using the bougie. And then I wanted to compare all of this to the last paper. And this paper just came out in Annals of Emergency Medicine, which is like our, probably the most widely respected emergency medicine journal. And this is a systematic review and a meta-analysis from 2024. And it included 18 different studies. And so if we remember the evidence-based medicine triangle, where we have a hierarchy of studies, at the very top, we put systematic review and meta-analysis in this triangle. And so we conceptually think of, a combination of lots of good studies as being better than a single good study, because randomized controlled trials is further down on this list. At the very bottom is simply expert opinion. You come back, you see a patient, and you come back and you ask me, and you're like, what would you do? And I'm like, oh, this is what I would do. That has some value, but it may be incorrect when compared to more rigorous studies. The challenge here is, do meta-analysis and systematic reviews always give us better information than a randomized controlled trial? And we've already seen that 2 different randomized controlled trials, which both overall had a good design, gave us drastically different results in a relatively simple trial. The question is, does a meta-analysis and systematic review actually help us more so than a single RCT? And the meta-analysis we'll read the conclusions first, that bougie for the meta-analysis was associated with increased first attempt intubation success. And they actually come to the conclusion that we should probably be using bougie first for our intubations. And so we have kind of what the studies that they included, some were randomized controlled trials. I think 9 of the 13 were randomized controlled trials. Some were observational. Some of the studies were done in the ED, but some were in the OR, some were in the ICU. Some were done by ED physicians, but some were done by anesthesiologists. Some of the intubations were done by critical care physicians. And so there's actually a lot of limitations. Not all of these were randomized controlled trials, a lot of settings outside of the ED. Some of these were things like elective surgeries, where if they decided that there was something complicated, they just cancel the case. And so they're not, in the ED, we don't get to cancel the case. There's intubators with very varied backgrounds and varied experience levels. And all of the different studies were very different, heterogeneous. They were very difficult to compare apples to apples, which is an English phrase. And also the definition of first pass success varied quite a bit. And so we have a combination of lots of different studies that may actually be measuring quite different things. You can imagine a study that's measuring, a very experienced anesthesiologist doing intubations in young, healthy people getting orthopedic surgeries. You might expect there to be a big difference in those results from a study that's done in the emergency department looking at people with difficult airways where you don't get the option to just stop going forward if you feel like you can't get the airway. Other outcomes that they showed is that there were, significant time differences. There was a wide range in how long intubations took. And then some of these studies, actually the majority of the studies showed that the intubation times were longer with the stylet than with the bougie. So even though first pass success was higher with the stylet, maybe it took longer. And in the ED, the differences between times weren't that much. And so maybe these are differences in the OR that are just not relevant for the ED. And then finally, for all of these studies, one interesting question is, we talk about first pass success, but is this truly a patient-centered outcome? Are we asking the right question, right? Because as we saw, there's differences in time that it takes to intubate, and we saw there's differences in mortality. There's differences in hypoxia. Maybe there's differences in hypotension, right? And so we may be measuring something that sounds good, first pass success, but if you're a patient and you choose a modality, the operator chooses a modality that increases the first pass success, but you also drop your oxygen to 20 and you end up with a hypoxic, like an anoxic brain injury, you don't actually care about that first pass success unless it's tied to a patient-centered outcome. And so is first pass success even the right question for us to be answering or asking? And logically, at face value, it makes sense, but we should also make sure that we're thinking about what is something that's actually patient-centered that we can measure that might make a difference. And so with this study, we get a different result from two different randomized controlled trials and a meta-analysis. And maybe in this instance, the meta-analysis is so heterogeneous and measuring so many different things that it's actually not higher. We can't value this higher than we can a well-done randomized control trial. And so this pyramid is not set in stone. It's a general concept, but it's not always true. And, when you have a meta-analysis or even a multi-center study, just like we said, when they did it alone at Hennepin, they had 96% success rate. Maybe the single center excellence, they are excellent at that single center, but that result might be washed out, might be eliminated when we average it across many different institutions. So of these three studies, what can we take away from this? And take into account, there's more studies too on this. Well, I just didn't want to muddy the waters too much. So the Bougie trial in 2021 says that there's no big difference. Basically, you can use either one. The Beam trial from 2018, by the same primary author, shows that there is a difference and that you should use a bougie as your first pass or your first attempt modality. And then the meta-analysis is actually also found a difference, but they favored, once again, the bougie and that it can increase first pass success, and that they suggest using a bougie. So what are our kind of take-home points about all of this? And then we can kind of maybe discuss what you guys plan on doing and how you're using like this in your department. And also maybe what we're doing to look, how do we search the literature? But I think what this demonstrates is that, we have an obligation to be searching the literature, reading the literature, and understanding the literature. It's very, very important to be reading the methodology. You can use the PICO method, but trying to understand these studies and not just read the conclusions or not just listen to somebody's guidelines, because in the methodology is where we find out the true value of the paper and whether that applies and whether that's something that should change my practice. And then just like the question of, is first pass success actually the right question for us to be answering? I think always make sure that the study that you're looking at is asking the right question for you to be, that you're actually trying to find the answer to. And then I think the overall take on bougie in this example of evidence-based medicine is that, most of these studies, it's either just as good or in some ways better than a stylet. And I think that we will see a movement towards using bougie as our first modality. Because the other argument is the more you practice with the bougie, the better you'll be when you encounter that difficult airway. So if we're all just using bougie when it's difficult, and we're doing the vast majority of our intubations with the stylet, that's not giving us the opportunity to practice with the bougie as well. And so we're not going to be as skilled. And when we really need to be skilled with the bougie is when the airway is particularly difficult. And so an argument could be made, maybe we should all be doing a little bit more like Hennepin, where we are excelling and being clinically excellent at using the bougie so that when we need it, we're better at it. And my personal anecdotal experience is that the bougie, for example, is a great tool when patients are getting compressions. I think it's really hard to intubate quickly somebody who's getting compressions. And we know from some of our other talks in previous history that minimizing compressions, for example, improves our outcomes in CPR. And so what can we do to make that rapid and accurate intubation? And in my practice, my experience is that bougie really helps you slot through the cords when you're only getting a glance every second or so. So any thoughts on or questions on the summary of evidence-based medicine and or use of the bougie? Di, are you going to start using the bougie as your first modality? Are you still out there, Di? How often? Yeah. Yeah. Yeah, I think, and this is what I've seen, in the practice environments here in the US, I've seen similar to that. Um, does looking at this literature change your guys' mind at all? Does that inspire you to start using bougie more frequently?
But how about your practice and your resident? You the bougie for the first attempt?
What's that for our residents?
Yeah, your practice every day and
Mhm.
your president. Now you the bougie for the first.
At our institution, they're still using stylet as their primary modality. I've encouraged all of the residents to use bougie first when they are intubating patients getting compression. So all the CPR patients. And in our system, our EMS is probably more like in Vietnam. They're not arriving intubated from the field, and so they get a lot of practice intubating patients getting compressions. Um, but I think or I try to encourage them, usually with the residents. I mean, when I'm teaching them, usually what I tell them to do when I'm with them is use whatever modality they're least comfortable with because I want them to be comfortable with everything. And so if they have used the bougie for their last 10 intubations, then I'm like, why don't you try, a hyperangulated stylet, or why don't you try some other modality? If they haven't used a bougie for many attempts, then I'll say, why don't you use the bougie as your first pass? Um, I don't, Juliet, are you guys making so I've kind of pushed for a move towards more use of bougie, but maybe like a 50-50 kind of spread, just so that they're using it more often. They're not only using it when it's difficult. Because I think if you only use it when it's difficult, I think you may not be as good at it compared to if you're having regular practice with it.
Yeah, I agree. Sometimes it depends on the situation. I encourage the residents to use it if they want to try something new, especially the second years. But personally, I wasn't trained that much with the bougie, and most of the literature surrounding first pass success with like the video laryngoscopy is pretty strong, which is what we use a lot in where I trained in Davis, which a lot of the times will require the hyperangulated blade and the stylet. I really only use the bougie for people with neck wounds when I couldn't see with the video and there was a lot of blood in the airway, like my upper GI bleeders.
Kit, you look like you have an opinion.
Yeah. Um, okay, as I talked before, and as you mentioned, we usually use Muji for difficult airway. So I just use Muji 2 times uh, in this department. So I think I need to do more with Muji to have more experience. Uh, and especially when I have difficult airway, I can have more experience in use Buji. Yeah. Mhm.
Yeah, and I think that is the great approach, and I think for everything in emergency medicine, I like to think of it, whatever we're doing, I like to think of it as having a large tool set, a large, choice of what we can do that works best in the circumstance. And so, whether it's managing pain, you should be familiar with more than one or two medicines to manage pain. And with intubating, you should have multiple choices available to you to adopt to what is most needed. And with vascular access, you should have a lot of different tools at your disposal. So I think this is the nature of an emergency medicine doctor is we're kind of flexible and well equipped to handle lots of different situations. So I think I really like that attitude of like, I need to practice this a little bit more. And maybe when we come in person the next time, one of these next times, if we include some airway work, we'll include some bougie practice. And so everybody can kind of get a sense and we can do some bougie practice.
Yeah.
And then is it helpful? We would like, we're sending you guys reading every week, and I know that you guys work way more clinically than we do, especially our trainees. We have the luxury of having more time to sit and read, but would you be interested if we start including like some the current literature on some of the topics that we're talking about, so you can kind of read through and maybe get a little bit of practice reading the methodology? Or is that too much reading and too much work? Dai, do you want us to be sending the literature? Yeah. Okay. We will not overwhelm you. We'll keep our ambitions low. But if at any point you find something interesting or you see a paper and you want to ask about it, or you would like to hear more about it, please just let us know. Because we tend to be overwhelmed with lots of the literature, so we're happy to share it. And I know it's sometimes hard to access from outside, so through our institutions, we can get it, so you don't have to pay for it. Um, so hopefully this was helpful and like a relatively simple. I think sometimes our residents are scared off by evidence-based medicine because they think of it as lots of math or lots of statistics, and it doesn't always have to be that. It can be pretty much simple understanding of the methodology. Any other questions before we go?
Maybe try to send the email sooner because the weekend for more time for reading.
What's that?
It means can you try to send us email sooner? Because usually you send email the 1 or 2 days before the class. Usually
Yes.
we were working on.
Yes, too, this is a great point, and I confess that I am guilty of that. So our goal originally was to send it a week before, and we have slowly been failing. I have been not, this is not a valid excuse, but I'm transitioning jobs. And so this last month I have been behind, and it was just bad timing because we are also running the module. So that is 100% my fault. And that's a great point. And we will recommit to sending you guys the information a week before so you have time to read. So thank you for saying that, because I am sheepishly in agreement. All right. Well, it's great to see all of you too. It's great to see you because I haven't seen you in a long time. Dai, as always, it's great to see you. Ket and the rest of the crew, it's great to see you. And the next module, it sounds Juliet is going to be managing the next module. And Juliet, you heard the request. We'll try to send out. I think Juliet was doing a good job of sending out the reading beforehand. And we'll also try to keep, one of the things we did this iteration was try not to send too many things for you to read, but just like one or two, so you're not overwhelmed and having a difficult time trying to read too many things. Because Dai, you make a good point. Maybe people don't always have time to read a lot of things, but we will keep it focused, and we will send it out a week in advance, or close to a week in advance, as soon as we can. And yes, thank you all. We'll see you soon. It sounds like, and then you guys will get to hang out with Juliet in person when she's there later next month. Yes. All right.
I will. Thank you, Di. Bye bye, everybody.
Thank you.
Bye-bye.
Mhm,
Bye
mhm.
bye, everyone.
Bye bye, Ryan.
Bye-bye.